My name is Carol Malumba, and I'm a cord blood survivor. I got the cord blood transplant in October 31st, 2008, and it is currently August 27th of 2021. So as you can see, the cord blood transplant worked, and I have been sickle cell free for over 10 years. I can't do math right now, but I just want to give a huge thank you to everyone involved, and even you right here, even if you didn't really actively help in my treatment. I still think you did, even if it wasn't direct. I am just blown away by all of the work and research and absolute dedication that all of you have. I remember reading about cord blood and never thought that we could get to this point where it could really help cure people. And there's still so much more we have to do. And I'm absolutely proud and just so amazed by every single one of you. And if you're ever doubting your work, your place in the cord blood registry, I just want you to look at me and every single other survivor. I mean, you helped me live the life I never thought I'd get to live. I got a new lease on life thanks to you. So thank you so much.
I always love seeing her talk. Okay, welcome back to the final session of this year's Cord Blood Connect. I am not Mitch. Mitch was supposed to be chairing this session, but he is unfortunately unable to be here, so you get me instead. This is a session on Mythbusters that we're going to talk about. We have the following speakers. This is going to run a little bit like the last session that we just did. We'll have the speakers come up. They've each been sort of assigned a myth to debunk. And then afterwards, we will open it up. Since Mitch is not here, we'll open it up. I've got a couple myths that I can throw out there. And we'll invite a couple other folks to come and talk about myths with cord blood, associated with cord blood and cord tissues. So I'm going to encourage you all as you're sitting there to think about any facts that you've heard or thought of, and that we can debunk up here, things that you think might not be true. You're going to be more than welcome to share those. Okay, so we'll invite Dr. Fran Verder up here from Parents Guide to Cord Blood, and she will do the first discussion.
This mic is not on. I'm using this mic? Okay. All right. I like to stand next to the podium because I'm too small to be seen behind it. Okay. All right, so thank you, everyone, for staying here to the bitter end, toughing it out. I know some of you are exhausted from last night. You know who you are. And I really appreciate your, you're going to applaud this. I appreciate your being here to hear my talk. I'm here to debunk the myth that cord blood banking is dying. I have a picture of a planned building implosion, which in the United States is a kind of a famous building. Does anybody recognize it? No, nobody. Okay. It's the Trump Hotel in Atlantic City. I knew that would get a laugh. Okay. All right. So here's the myth. The list of myths that I'm going to try to tackle. The myth that, and I'll explain to you why it's a myth, that very few cord blood transplants are taking place. There are rumors that, gene therapy is going to replace cord blood, replace transplants in general, for certain diseases. There's been a lot of press about that, but is it true? Going to talk about the numbers of family cord blood banks and their distribution. Are they healthy or not? And there's also a story going around among the family bankers that there's just a few companies that control most of the industry, and that's also a myth. At the same time I'm doing that, I'd like to make a few constructive suggestions for improvement. My main suggestion is going to be better networking among worldwide cord blood banks. I'm also very concerned, and I think all of you are very concerned about messaging that HEMOCs put out. Hematology and oncology doctors are very often bad-mouthing cord blood, particularly in the West, in the US and in Europe. I think it's a big problem, and I don't know how to, I mean, we really need to work together as a community to try to change that negative perception. And then at the end, I also want to talk about the use of both cord blood and birth tissues can be very important sources for clinical trials, which is something that's been discussed a lot today. Okay, so this is the biggest thing that I want to address with everybody. We have over 200 people registered for this conference. And I think all of us rely on the World Marrow Donor Association as the holy grail of how much cord blood is in public banks and how many transplants are taking place. And I myself always just assumed that their numbers were correct and quoted them. But over the summer, I accidentally discovered that their numbers are extremely wrong in Asia. So if you look at their graph of how many transplants are taking place per year by geographic region, you see this problem that we've all been talking about over and over, that transplants peaked around 2014 and have dropped a lot since then in the West. The black line represents Asia, and it's continuing, but it's kind of flat. If you look at the year 2020 specifically, these are the geographic regions that WMDA has. So what they call Asia combines some countries that are very active in cord blood transplants, like Japan. South Korea releases a lot of units for therapies, whether or not they're transplants. It includes China, it includes India, which has a ton of cord blood banking, but a limited amount of transplants. It's very small. It includes the Middle East. For the year 2020, WMDA was saying that within all of Asia, there were 1,658 transplants. But simply reading the websites of cord blood banks in China, I discovered that from 6 banks, I could put together 4,907 transplants, nearly 5,000 transplants, like several times more than what WMDA was reporting. And I started going back and forth and checking, could this really be true? Where was WMDA getting their data? I turned out that they were only getting data from a single bank in China, and they thought that that data was representative of China. I'm not here to bash WMDA. I had a big conversation yesterday with Martin Myers about the fact that we need to sit down and work out better networking. I know people who are in China, I know people who know people in China, and we need to actually get data from them and get it into the WMDA numbers, because everybody who comes to conferences thinks that that's the holy grail, and it's way wrong. In terms of inventory, for the last complete year, 2022, they were reporting about 200,000 cord blood units in all of Asia, and that even includes the Middle East. But by my estimates from the websites of Chinese banks, which I simply read with Google Translate, anybody can do this, I found several banks that added up to about 400,000. There might even be 500,000, and these are public units. So if we included these, instead of saying that in the whole world there's 800K public units, it's actually over 1 million. There's at least 1.2 million in public units worldwide. So this changes the world picture. Everything we said here about collapsing use of public banks, that's true in the US, it's true in Europe, it is not true in Asia. We really need to have a more realistic view of what's going on in the world as a whole, when we try to talk about the health of cord blood banking. And also in May of this year, so just at the beginning of the summer, China held their 10th National Cord Blood Conference. Notice they've been having national conferences for 10 years. And at that conference, one of the leaders of their community said that uses of cord blood had exceeded 85,000 worldwide. Whereas what we have been quoting, we Westerners have been quoting 40K. It's actually 85K, and 30 of them are in China. I mean, it's a big, big change in your perspective if you have the correct information. So we need to work on better networking. That's basically what I say here. Broke that myth, suggested improvement, better networking. Okay, so another myth I want to talk about is the belief that, oh, gene therapy is going to replace stem cell transplants, especially for hemoglobinopathies like sickle cell disease and thalassemia. And I published an article in newsletter of my foundation in August that has a long, long discussion of this, complete with references, more details than I've got here. But hemoglobinopathies are genetic mutations that affect red blood cells. And this is a schematic of it that I got from CRISPR Therapeutics. In sickle cell disease, the red blood cells really are sickle-shaped, and there's a big problem that they tend to stick to each other, and they block capillaries all over the body, and these cause pain crises. There's chronic pain for sickle cell patients. Thalassemia patients do not have pain crises, but they have even more severe anemia. They have a tendency to be transfusion dependent, which leads to long-term problems. You have iron buildup in the body, you have multiple organ damage. So both of these diseases can be treated short-term by multiple transfusions, but in the long term, only a stem cell transplant will correct it. And sickle cell is a monogenic disease in the sense that there's a single gene that causes the problem. So if you fix that gene, you fix the disease. That's why it's a wonderful candidate for gene therapy. Thalassemia is actually, there's multiple variants of thalassemia, like way too complicated for me to discuss now, but the most severe form, beta thalassemia major, is also monogenic. So yes, they are wonderful candidates for gene therapy, but is it realistic to believe that that's going to replace transplants? And I'm going to argue that the answer is no. First of all, to get an idea of the huge scope of this, these are among the world's most prevalent diseases, certainly among genetic diseases. 7% of people worldwide are carriers of one of these diseases. But when you look at where the patients are located, they tend to be in an equatorial band. It turns out that being a carrier of one of these diseases gives you protection against malaria, and that explains why patients have not died out, that they actually have an advantage in terms of evolution for surviving malaria. A recent survey showed that 3/4 of all sickle cell patients are actually located in Africa. 95% of sickle cell patients are in a country considered low and middle income. So I'm going to come back to this later, but we have a situation where the expertise in stem cell transplants is located in, centers of excellence like the Hutch, or Memorial Sloan Kettering, whereas the patients are all located in places like Africa and India. That's a kind of a supply chain mismatch of where there's a need versus where we have the ability to supply it. This is a schematic, which I also got from CRISPR Therapeutics. They seem to have a really good graphic designer. The current method, in terms of the therapies that have FDA approval or are very close to FDA approval, the current method of treating hemoglobinopathies with gene therapies is to combine, to piggyback the gene therapy on top of a stem cell transplant. So you're already giving these patients an autologous transplant with gene therapy added in. So you can easily make the leap that doing that is going to be quite complicated and expensive, and that if you want to treat patients in low and middle income countries, it would be easier to just give them a stem cell transplant without having to do the gene therapy. So I'm not going to go through everything in this table. Most of this table was in the blog that I published in August, except for the prices column. I didn't include in the blog, but you can ask me for the slide, or I can I can email it to you, whatever. There's an interesting question of whether or not a therapy is cost effective. And cost effective is calculated on a national basis. It factors in how many patients are there and how big is your budget. So, for example, the FDA has approved a gene therapy for thalassemia from the company Bluebird Bio. It actually costs $2.1 million per patient simply for the gene therapy. That's not even counting the hospital stay. And yet, $2.1 million is considered to be cost effective because in the United States, there are only between 1,000 and 1,500 thalassemia patients that are transfusion dependent and are eligible for this therapy. So yes, our budget is big enough to pay 2.1 million times 1,000 patients. That would not be cost effective if you tried to do gene therapy in Africa or in India. This is another reason why stem cell transplants continue to be very competitive for treatment of these diseases. But by comparison, in India, they have 12,000 births per year that have beta thalassemia major, the most severe form that could benefit from a transplant. So 12,000 births per year, and compare that to a grand total of maybe 1,500 patients of all ages in the US. You know, this is why it's cost effective to give gene therapy here, and it's not in low and middle income countries. That's part of the equation. There are several drugs that have been approved for sickle cell. They work by making the red blood cells a bit more slippery or a bit more flexible so that they're less likely to stick to each other in capillaries. But financial analysis of those drugs, they're not considered to be cost effective because they cost between $30,000 and $90,000 per year in the US. So even in the US, they're not considered to be cost effective. So really, if you want to look at the world as a whole, where it is cost effective, there's a very old drug called hydroxyurea, which helps sickle cell patients. It's actually a chemotherapy drug, which was discovered to help with sickle cells. And then there are basic transplants, like cord blood transplants. In the US, the RAND report, which is getting a bit out of date now, but the RAND report estimated the cost of a cord blood transplant as about $800K, and that was factoring in 7 weeks in the hospital. In India, the transplant alone is INR 20 lakh. Lakh is an Indian term for 100,000. Okay, so another important thing is that in July this summer, the Lancet Hematology Commission published an entire issue of the Lancet Journal dedicated to the treatment of sickle cell with huge discussion, entire articles about disparities, about prevalence, and they came up with a list of about a dozen recommendations. And this, really high-level commission, a couple of things they recommended was systematic screening of newborns, that every country in the world should be screening newborns for hemoglobinopathies because 7% of babies are carriers. They're also saying that for children who are diagnosed with the disease, there should be universal HLA typing, which of course it's easy for them to propose. It would be harder to do that. And they're also calling for increased use of stem cell transplants in low and middle income countries. Like for example, India, South Africa. These are countries that have cord blood banks, but very little transplantation. So that's a growth area for our community. And this basically summarizes my points. I think I made that already. So the new transplant program should copy some existing success stories. We do have low and middle income countries where there are cord blood transplants to treat, for example, thalassemia. So there are models to copy from, and it always depends on the regulations in individual countries as to what is or is not feasible. All right, myth number 3 is that the numbers of family cord blood banks have dropped dramatically. When my foundation, or in other words me, looks at cord blood banks, we divide them into laboratories versus marketing offices. And it is true that there has been a drop in marketing offices that is pretty dramatic. But if you actually look at the number of laboratories over the past 8 years have only dropped by 14%. And a great deal of the drop in marketing offices was due to the closure of CryoSave in Europe during the past 8 years. So yes, number of family cord blood banks are decreasing, but not dramatically. And despite the fact that numbers of banks are decreasing, there are nonetheless 97 countries around the world that have family cord blood banking. In this graph, I counted the number of brands in each country, and so brands is a combination of either a bank with a lab or just a marketing office of a bank. There are about a half a dozen countries that have 10 or more brands: the US, Romania, Brazil, India, Argentina, and China. And that leads to the question of who owns these labs and these marketing offices. Now, it is true that there has been some consolidation which has created large conglomerates. To my knowledge, there are 3 banking conglomerates that have over 1 million cord blood units in storage. There are a half a dozen companies that have 4 or more laboratories. These laboratories are typically in different countries for a multinational bank. And that is sometimes required by regulation, because there are some countries that require, if you're going to collect private cord blood units in their country, you need to have a lab in their country. And those are not even old regulations. More countries are passing that kind of law. Like within the past couple of years, Vietnam and the United Arab Emirates started requiring an in-country lab. And then there are some banks that have large numbers of offices where it's all being shipped to a central lab. Finally, some banks mix and match these 2 models, like, for example, Cord Life, a bit of both of these business models. And yet, despite all of this consolidation, when I went through the data, I found that 72% of family cord blood banks only have 1 lab. So yes, there is consolidation, but we still have a lot of banks out there that have a single lab focusing on a single country. You know, the concept of mom and pop banks that are focused on their home market still exists, still healthy, they're still doing business, so they're not going away. All right, so this is a slide on the topic of messaging. I read an article in a North Carolina newspaper, I forgot which city it's from, but they were telling a patient story about a kid that got a cord blood transplant. So of course, whenever I see these stories, I always read them in detail because I'm thinking, oh, maybe I can use this as a patient story. But this particular story had a sentence in it which prevented me from using it, which said that the family didn't find a bone marrow transplant, so they had to use the second best option of a cord blood transplant. I was thinking to myself, why did the reporter say that? Why did the reporter say that cord blood is second best? And I'm sure that the reporter doesn't know that. So what probably happened is that a doctor told the parents that cord blood is the second best option, and then the parents repeated it to the newspaper. You know, and this, you know, connects to my problem that we have a messaging problem, that cord blood keeps being portrayed as the second best option. At least in the US, that is the case. You know, whereas if you go to other countries, cord blood, I've seen news reports about cord blood that come out of some Asian and Middle Eastern country where it's talked about as the elixir of life, that this child's spark was saved and rekindled the fountain of life in him. I mean, just glowing reports, and we don't get that here. Use of cord blood and other perinatal tissues in clinical trials. So my group has spent the past 3.5 years tracking cell therapy for COVID in great detail. This is a graph of 3 years worth of trials, 2020 through 2022. Over those 3 years, 41% of the cell therapy trials for COVID used a perinatal source. And the majority of these were using MSC from either cord tissue or placenta. But there were also trials that used NK cells from cord blood, Tregs from cord blood. So there's also about 25, I forget the exact percentage, about a quarter of cell therapy for COVID is immunotherapy, not MSC. A lot of people don't realize that. And some of that immunotherapy is sourced from cord blood. So this shows you that there's a big opportunity for banks that are actually isolating cells from perinatal tissue and banking something which is clinically valuable. There's a big opportunity for them to get involved in clinical trials or, to come forward as saviors during a pandemic. When you look at where the clinical trials of cell therapy for COVID took place, and in this graph I'm only showing 2 years worth of trials, the first 2 years of the pandemic saw trials in 30 countries. And I think it's really important to look at that carefully. The leaders, well, a lot of people don't realize that Iran was number 3. It was the US, China, Iran, but then when you get down deeper into it, you see countries, I don't want to disparage anybody, but countries that are not considered to be, on the front edge of cell therapy research, which were nonetheless running trials, which goes to show you that anybody who had cells in a biobank that had a safety profile was using them clinically during this pandemic. And I think that's a lesson learned for future pandemics. Everybody expects there will be future pandemics. We want to have cells in a bank, preferably a local bank, cryopreserved, so that if the borders are shut, you've got cells that you can use for cell therapy in a pandemic. So I think local biobanks have a particularly high value that some people are overlooking in the rush to consolidate or to look at big brand name companies that did a lot of press releases about their trials. The majority of COVID trials used a bank that was local, very often in the same hospital where the patients were treated. So that's my myth-busting summary. I would say that the cord blood banking industry is evolving. I heard Calvin Cole use the same phrase yesterday. And there's more banks and more transplants and more inventory than most people realize, but we need to do a better job of tracking the worldwide trends. We need to do a better job of communicating. There's a bit of a supply chain issue of where we have the transplant expertise versus where the transplant need is. We could hugely increase the number of transplants per year by promoting programs that treat sickle cell and thalassemia. Like, for example, if we brought in fellows from countries that have high incidence of those diseases, train them here and sent them home to start programs. And gene therapy is not replacing stem cell transplants anytime soon. There is research on in vivo gene therapy where you don't have to combine the gene therapy with a stem cell transplant, but it is way down the road. So we've got at least a decade of stem cell transplants being the dominant treatment. And that's it. That wraps up my talk.
It's a surprise on who's next. Let's see. Okay, Junya, can you please come up? Welcome, and you can talk to us about your myth. Do you need? Oh, you okay?
Okay. Hello, everyone. I'm Junya Kanda from Kyoto University. I'm a transplant physician, and today I'm very glad to be here. And today I'm going to talk about similarities in CBT between Western and Asian countries. I don't have any COI to disclose. Yes, I heard that such kind of a myth that the UCBT in Japan is very superior. So UCBT in Japan is completely different from the UCBT in the United States and Europe. And the result cannot be shared with each other. Today, I would like to persuade you that this is not the true. This is an overview. First, I'm talk about trends of UCBT in Japan, and then the similarities and differences between United States, Europe, and Japan, as for the following items. First, owing to the development of PTCY, also in Japan, the number of haploidentical transplantation is increasing and reaches 700 per year. But also, unrelated cord blood transplantation, the number is gradually increasing. It almost peaked, but still 1,300 transplants per year. So Japanese outcomes, transplant outcomes was bad 20 years ago. As shown here, neutrophil engraftment was nearly 70%, and this is misprint, but all the age is this blue line. So NRM was almost 20% in 100 days. That is very bad, but in 20 years, we developed the GVHD prophylaxis, new GVHD prophylaxis, conditioning regimen, and supportive care. And finally, we could improve the cord blood outcomes of cord blood transplantation. And then let me talk about similarities and differences. There are several differences between Japan and West countries, regardless of stem cell sources. Risk of acute and chronic GVT is slightly lower in Japanese population. I don't know the exact mechanism, but probably differences in SNPs for some immune modulators. And as a result, non-relapse mortality is generally slightly lower in Japanese population. And clinical practice is very different, and also insurance system is different. Patients can be hospitalized for 2 or 3 months after transplantation, so that's okay. And Japan is very small country, so it's easy access to hospitals. That's the difference. And body weight is lighter, but sometimes access to new medicine is delayed. This is an impact of race on GVHD after HLA matched sibling BMT or PBSCT, so HLA matched. And I compared Caucasian and Japanese populations. As shown here, grade 3, the incidence of grade 3 to 4 GVHD was slightly lower in Japanese populations, regardless of the sources. And also, this is chronic GVHD, as shown here. Incidence of chronic GVHD is lower in Japanese populations, especially in PBSC. And as a result, treatment-related mortality was lower in Japanese population, but it's not cord blood, but BMT or PBSCT. So that is a slight difference. And then let me talk about CBT. I have a chance to collaborate Eurocodes, and we published the paper, and I will explain according to the paper. And number of HLA mismatches is different because our counting method of HLA is different. We counted DLB1 as an antigen level, maybe here HLD1 allele level. So that's why we have more 3 mismatches in Japanese populations. And TNC is different. TNC is 2.58 times 10 to 7 per kilo in Japanese population, even though we are very light, And actually, we want to choose better cord blood unit, but we cannot find a better one, And today, chief in Japanese cord blood bank is sitting over there, so I hope that he will agree with my opinion. So please double of the cord blood bank storage. And transplant characteristics that's a very old cohort until maybe the 2014, so a little different at the But TBI usage is lower in European populations, and ATG use was high, very high in European cohort. Also, methotrexate was frequently used in Japan because MMF was not approved by the Japanese FDA. But now it's approved, and maybe the 50 and the 50. And we have compared the outcomes between MMF and methotrexate, and the results are almost the same. And transplant centers are very heterogeneous. In Japan, 200 Japanese centers contributed the data to the cohort. So, so many centers are performing cord blood transplantation. That's sometimes it's a problem because there is a huge center effect among that. So, but at the same time, EBMT centers, 135 centers in 25 countries participating in this study. And origin of UCB grafts are 11 public banks in Japan, but now 6 public banks, and so it's easy to keep good quality among the cord blood banks. And during the period, 5 public banks contributed the cord blood in EBMT cohort. And this is overall survival in AML and ALL. As shown here, the Kaplan-Meier curve almost similar, but the 3-year OS was slightly different, 41% versus 33%. And this is other transplant outcomes. Non-relapse mortality at 3 years was significantly lower in Japanese population. On the other hand, grade 2 to 4 acute GVHD was high in Japan. Why? I think that during that time, ATG was frequently used in Europe. So, as you know, ATG was associated with worse overall survival and higher non-relapse mortality. So it may decrease acute GVHD, but it will increase non-relapse mortality during that period. And this is not AML or ALL, but lymphoma, and comparing the Eurocode and JST Japan, and stratified by the disease risk index, relapse risk, low, intermediate, and high, very high. As shown here, overall survival looks very similar, and also furthermore, in high or very high disease risk group, Japanese data looks worse than Eurocode. So by this slide, I can say that Eurocode data and JST data is very comparable regarding the lymphoma CBT. Also, Dr. Watanabe's work, we collaborated with Fred Hatch and Japanese National Cancer Center and the Kyoto University Hospital, and all of 3 hospitals are very experienced centers, And this showed that the comparable relapse-free survival, but maybe the disease, according to the disease risk index, low intermediate risk groups, Japanese showed a better result, but Japanese survival rate looks worse in very high or very high disease risk index group. And relapse incidence looks higher in Japanese cohort. So I can say that if we focus on the experienced centers, we can show the similar results in cord blood transplantation. I think this is very important. And move on to the cord blood selection. Yes, as you know, in the United States, there is a guideline, and TNC dose single unit 2.5, and CD34 dose is 1.5. And HLA matching 6 loci, 4 out of 6, and 8 allele, 4 out of 8. How about in Japan? In Japan, cutoff is slightly lower. TNC is 2.0, and CD34 is much lower, 0.5, or if possible, we try to find a larger unit with CD34 cell dose, but it's very difficult sometimes, but try to find more than 0.75 actually. And sometimes we consider CFU-GM, and HA matching is completely the same. So selection criteria look similar. There is a difference in cutoff, just cutoff. But we want to choose better one. So this is to find a better, good unit, cord blood unit easily, we are making a scoring system using a CD34, CFU-GM, sex mismatch, LTL mismatch, and the antibody. And we could categorize into 5. And group 1 showed a very good neutrophil engraftment instance. But we want to choose that the CD34 more than 1. So that sometimes it's very difficult because we cannot find actually. Not just 10,000 cord blood units are stored in Japanese cord blood bank. And if we choose a good cord blood unit, CD34 CFU-GM, maybe we can obtain the better cord blood outcomes. So yes, finding better cord blood unit is very important also in Japan. Move on to the conditioning regimen. Yes, this is I like the regimen so much, and through CPS, TBI showed very good result in memory strong catalytic. And we want to use this regimen, but unfortunately, Cyotaper is not allowed to use for allo-HSCT in Japan. But then, what kind of the conditioning regimen is used in Japan? In Japan, for young patients, we use RC, CY, TBI. That is shows a very good results, so we try to use it for young patients. Other than that, we use these fludarabine melphalan-based regimen. Fludarabine melphalan 80 plus busulfan, or fludarabine melphalan 80 or 140 plus TBI. This combination yields a very good result. I will show that one of them. This study compares the conventional myeloablative regimen versus flu-bu4 mel 80 for non-remission AML. So a lot of blast sometimes. But please see, as shown here, fludarabine busulfan melphalan regimen showed better overall survival, lower relapse risk, and similar non-relapse mortality. Also, the grade 3 to 4 GVHD are high among population. So for high-risk AML patients, we frequently use this regimen, and we use cord blood instead of the Haplo. But there is a problem, center effect. This is our Kyoto University study group, and we pick up the top 5 centers regarding as for the number of cord blood transplants. So this is the number of cord blood transplants during some period. And it showed that outcomes are very heterogeneous, Kyoto University, yes, very showed good result, but that's very difficult to obtain a similar result. And maybe yesterday, Dr. Barker said that successful cord blood transplantation requires close multidisciplinary collaboration, education, and experience. I quite agree with that. We need to educate other centers. So maybe that we need to make CBT network also in Japan and share the experience to minimize the center effect of CBT and improve CBT outcomes. And in summary, there is a small difference in outcomes between United States, Europe, and Japan, regardless of stem cell sources. This difference does not require change in CBT policy. Cord blood selection criteria are similar, and concept of conditioning regimen for CBT is similar, but regimens are slightly different due to availability of drugs. And as long as the conditioning regimen and UCB unit are selected appropriately, superior UCB results can be expected in both United States, Europe, and Japan. And result of CBT studies and new strategy for UCBT can be shared in United States, Europe, and Japan. So I hope that I could busted the myth. And I would like to acknowledge all physicians and data managers who contributed the valuable data to EBMT, Eurocode, and JSTT. And also, I would like to acknowledge Eurocode, EBMT, and the Fred Hutch Cancer Research Center. And thank you very much.
Thank you so much. That was great. I realize I haven't asked if people had questions for the speakers, but we'll have you go, and then we can do that after. Okay? We'll have plenty of time.
I'm also quite short, so this platform would definitely help. Hi everyone, I'm Sang Hyung. I'm a leukemia and bone marrow transplant physician from Duke University, one of the junior faculty. And thank you so much for the meeting organizers for inviting me for this talk. And also thank you everyone for being here until this end of this meeting and paying attention. And this has been so fruitful meeting so far. I do not also have a conflict of interest to disclose. The myth that I'll be busting is that the BMT CTN 1101 trial showed a clear advantage in haploidentical donor transplant over the cord blood transplantation. So the BMT CTN 1101, that was the randomized control study that I'll be going over a little bit in details. So I'll be going over the results of this study that have been published in 4 different publications. So there was an original publication back in 2021 in the original 2-year clinical outcomes, followed by last year there has been the 5-year clinical outcomes of this study. Then also this last year has been a publication on the patient-reported outcomes of quality of life pre and post-transplant. And also this year, earlier part of this year, has been the cost-effective analysis has been done. So those are the ones to go over. So BMT CTN 1101 was a multi-center phase 3 1-to-1 randomized controlled trial for high-risk acute leukemia or lymphoma patients randomized to go to double umbilical cord blood transplant versus haploidentical bone marrow transplant with post-transplant cyclophosphamide using reduced intensity conditioning of fludarabine, cyclophosphamide, and total body radiation using graft versus host disease prophylaxis of cyclosporin with mycophenolate mofetil versus post-transplant cyclophosphamide with tacrolimus, mycophenolate mofetil for adult patients aged 18 to 70, and total of 368 patients from 33 US centers were randomized for this trial. This is a study schema showing the slight differences in the regimen, but pretty similar. So top, the A is a double umbilical cord blood transplant regimen. So basically pretty similar, except for a little bit of a differences in a pre-transplant cyclophosphamide dosing and when to start the immunosuppressant based on if for the haploidentical bone marrow transplantation required the post-transplant cyclophosphamide. And then the primary endpoint for this study was the 2-year progression-free survival. And initially when they launched the study, they felt that for the power analysis need 410 patients to randomize to see the clear differences in progression-free survival. Unfortunately, this study, as many of you know, had a challenge in terms of the accruing patients. So total at the end had only 368 patients. And then this initial, outcome has been published, the primary outcome of the progression-free survival at 2 years was not statistically different. However, what was noted in the study was that the 2-year overall survival was different and it was statistically better for the haploidentical bone marrow transplantation. And this was felt to be led based on the 18 months non-relapse mortality that was better in the haploidentical bone marrow transplantation, and relapse rates were not significantly different. So far, probably that study was what a lot of people are already aware of. And then in the last year, there have been a 5-year follow-up that now know that the 5-year non-relapse mortality are still significantly different, so that there is an advantage in the haploidentical bone marrow transplantation. So it was 10% at 5 years versus 24% for umbilical cord blood transplant. But otherwise, the relapse, progression-free survival, or overall survival were not statistically different. So just to note that what was significantly different at the 2 years did not pan out anymore. So then, in terms of looking into the clinical outcomes, then more questions do remain. So again, when we look into it, in the long-term outcomes, the overall survival were statistically similar between haplo and umbilical cord blood transplant. And early outcomes show that there is likely advantage of the post-transplant cyclophosphamide-based GVHD prophylaxis in terms of a benefit in non-relapse mortality. And this study of note did not study the myeloablative conditioning, and this study also did not just use a double umbilical cord blood, did not use something like the omidrucel graft. The next publication on this study that I wanted to go over was the quality of life. So quality of life is one of the patient-reported outcomes, and this study have used many different measures. So that included a FACT-BMT, SF-36, EQ-5D, and occupational functioning scale. So those are basically a pre- and post-transplant, how patients physically, mentally, socially cope with the situation, and how they have symptoms related with the transplant. And the last scale was looking mainly into how the patient is able to go back to work, in what capacity. And the study time points were at pre-transplant at the time of the enrollment, and 12 and 24 months post-transplant. And as you see that there have been no significant differences in any of the quality of life raw scores at any point of the time. So what you are seeing on the left side is the FACT-BMT total score, and then there is the EQ-5D, which is mainly used in the Europe utility score, and then the physical functioning score and the PCS that you're seeing on the right. All those did not show the statistical difference. Rather, when they're analyzing the data, that were noticed that when the patient experienced events such as relapse or chronic graft-versus-host disease in the EQ-5D, or had a grade 3 to 4 acute GVHD, then they noticed that there is a decrease in their patient's quality of life. So the conclusion of that quality of life publication was that patient who underwent the reduced intensity double umbilical cord blood transplant and haplo bone marrow transplant had no significant differences in their pre- and post-transplant quality of life. The clinical events such as a relapse, grade 3 to 4, acute and chronic GVHD were associated with worse health-related quality of life. And again, the health-related quality of life measures did not associate it with the clinical outcomes such as overall survival or progression-free survival. So then the fourth study that had been published on this study was, I'll go back to this slide a little bit, is on the cost-effective analysis. So cost-effective analysis is it can have many definitions on it. So for this study, they have used the definition of cost effectiveness as the differences in the mean cost of the umbilical cord blood transplant and then the haplo bone marrow transplant divided by how much of a gain in a quality adjusted life years. So in terms of this study, they actually used a cost analysis based on how much of a claims in terms of the payments went through the insurer. So that was the cost use was not able to accommodate for the all costs associated to it. And when they're seeing it, then they notice that there is increment differences in the cost. So in this analysis, they had to divide the study based on whether patients were less than 65 years old, which mainly used the private insurers, versus those who were older than or equal to 65 years who used Medicare as their payers. So what you're seeing it for, I'm not going to go back, is that for those graph on the left, who are on the left side and the less than 65-year-olds who are mainly paid by the private insurers, what we actually saw is that cord blood transplant was actually less costly compared with a bone marrow transplant up till about 3 years. That's when they were able to accommodate for, and those cost differences were thought to persist throughout the 20-year period. So what they see is that the Haplo bone marrow transplant expect to be potentially more effective and more costly in the less than 65-year group. And for greater than or equal to 65-year-olds, what they were seeing is that the Haplo transplant was more effective and also less costly. What I wanted to mention to you is that these numbers actually came from that 5-year analysis. So there is a flaw in this study that they have used a median number that we, at the end, when we compare those overall survival, those were not statistically different. So this was the best accommodation they could do in terms of analysis, but I would say that this was also not completely perfect. And what they also see is that for those less than 65 years old who are commercially insured, they saw that those cost effectiveness would be kept close to about $180,000 to $200,000. That would be how much the insurers should be usually willing to pay. But again, this had a lot of some of the flaws in terms of their calculation as well. So for this cost-effective analysis, the conclusion was that the umbilical cord blood transplant is more cost-effective for recipients who are less than 65 years based on their private insurers using. In contrary, Haplo bone marrow transplant was shown to be more cost-effective for recipients older than or equal to 65 years using Medicare. So I hope that I helped busting this myth that we did not actually see from BMT-CTN 1101 trial that Haplo donor transplant was clearly better than cord blood transplant, mainly because that long-term overall survival and progression-free survival were not statistically different. Also, quality of life that were reported by the patients were similar, and also less than 65 years those patients, the umbilical cord blood transplant was also less costly. I wanted to mention that CTN 1101 was one of the many efforts trying to look at different sources of the donor. And there were 3 other studies that I was going to briefly mention before going into the conclusion. So there was a study that was done at in the European sites in the EBMT that was published back in 2019. This was an open-label prospective multi-center trial using 6 EBMT centers. This was 1-to-1 randomized as well, using either single unit cord blood transplants versus the Haplo donors who are going through the myeloablative conditioning using busulfan, fludarabine, or thiotepa conditioning. And GVHD prophylaxis used for the cord blood was a cyclosporin with the prednisone, and for the Haplo was the post-transplant cyclophosphamide with the cyclosporin with the mycophenolate mofetil. This study had a very small number of patients, only a total of 45 patients. Of note, though, that those patients were assigned to the haploidentical group. 4 out of those 26 patients were not able to find the donor source. So they had to cross over to cord blood because of the unavailability of the donor. And this study had a total of 32 months of a follow-up. And as you see, what you are seeing is that there was the statistical difference in a neutrophil recovery. Yes, it was slightly faster in a haplo, but the non-relapse mortality was not statistically different. 2-year disease-free survival and 2-year overall survival, although you were seeing the differences, were also not statistically different yet. But the 2-year graft versus host disease-free and relapse-free survival were different, so that in that case, the cord blood transplant was worse compared to the haplo transplant. When we're looking into the post-transplant course events, those individual events were not significantly different except for more rates of the hemorrhagic cystitis in a haplo transplant group. And causes of deaths were varied in these group as well. So conclusion from this European study of the single unit cord blood transplant versus haploidentical, the myeloablative conditioning transplants, they had a so far non-statistically different 2-year disease-free survival and overall survival. However, 2-year graft versus host disease and relapse-free survival was better in a haplo transplant, likely because of the higher non-relapse mortality in the earlier part of the transplant. And in this study, we saw that the finding the donor in a haploidentical transplant was an issue, but this study had a drawback of having a relatively small number. 2 other studies that were able to be found from the clinicaltrials.gov actually did use more of a haplo-cord combination compared with the haplo transplant. But I wanted to mention that from these studies, what we are seeing is also that had a similar clinical outcomes for those who were transplanted less than 60 years at the time of the transplant. 4-year overall survival and 4-year progression-free survival were pretty similar. And then the last one that was shown in an abstract form in the last ASH meeting, 2022, also showed that the haplo-cord transplant versus haplo transplants had a similar clinical outcomes based on complete remission rates, 3-year overall survival rates, and 3-year progression-free survival rates. But what they have noted is that those used haplo-cord transplants, once they have survived the first year, so that means basically negating all the early non-relapse mortality differences, then haplo-cord transplant survivors did better at that 3-year overall survival and progression-free survival. So again, what I wanted to mention is that from those 4 studies, we know that there are more data needed to actually make a conclusion of whether that umbilical cord blood transplant is better or worse versus the haploidentical transplantation. As we know of, each of the transplants have advantages and disadvantages. But I wanted to mention that from these studies, we also saw that cord blood transplants have more availability. At least for the experienced centers, we are able to see the comparable outcomes or sometimes better in some of the situations. And then the cord blood transplants also have a possibility for the expansion as we see for those the omeprazole products. So that was it for my talk. So I'm going to bring the rest of the group back.
Ooh, look, now I can be all tall. Before we go on to some more myths, I want to make sure we have a chance to, hold on, Karen, that we have a chance to ask the speakers any questions you might have after their excellent talks. Filippo?
Yeah, I'm sorry, Colleen, it's not really a question, it's more a comment, and I think this is the great job with the presentation. This is a perfect way to end the meeting because kind of attaches with our first sessions 2 days ago. And a comment is regarding 1101, and I know that things have been recorded here, so I hope they are, because it's been one of the most useless clinical trial ever run in the United States. And the main reason is because it was so outdated, and from both sides. So first of all, we don't do any more haplo bone marrow. The majority of things are haplo peripheral blood, and that's it's one of the problems. Also from the other side, there are some issues. But for cord blood, I'm pretty sure you all know that it's very rarely used for patients over 65. So even the quality of cost analysis is something that we don't even take in consideration. And the damage that that study has done to the field is immense, because that conditioning regimen that is being used for the trial, which is Flu-Cy, TBI, conditioning regimen, is not only outdated, it doesn't work for cord blood patients. As a matter of fact, Fred Dutch in Seattle, we participated to the clinical trial, so we enrolled 3 patients, so very minimal participation from our side. And the reason why we did not participate is because we already knew that the experience with that conditioning regimen was extremely bad. So we had an overall survival of 20% for patients undergoing cord blood transplant. And the other things that people forget to mention is that if we set what we propose to our patient, the results are not great, because an overall survival, progression-free survival of 25 or 35%, it's not satisfactory for our patients. So no matter what, it was a failure from my side, from both sides. So it's just a general comment that I think was going to attach to the last presentation. And I do have a question for Junia. Actually, I loved your data, and Mizuki did a wonderful work when she was in Seattle. And one of the things that I noted, though, is that we do use cord blood mainly for lymphoblastic leukemia and myeloid leukemia, and while you use also for lymphoma more than we do in Seattle. But I was surprised more about the good impact that you are seeing with the use of melphalan as part of conditioning regimen. And because as my experience is that is really associated with a lot of toxicity, especially mucositis, and I would like to hear your opinion about it. Thanks. Sorry for the long comment, Colleen, but I think it was
great. I mean, it's very important, and yeah.
Yes, fludarabine melphalan, yes, for United States doctors, melphalan is dose of the melphalan is high sometimes, and maybe may toxic to the mucosal. But for our experiences, it was not so bad actually, and especially fludarabine melphalan 80 TBI 4 gray is very easy to use for elderly patients such as 6 until 70 years old, very easy. So yes, if you use that regimen for that kind of the population, maybe I hope that you will have the same experiences. But yeah, I really want to use Cyotipa instead.
Great. Any more questions? Joanne, Filippo, Karen, you want to join us up here? We're really because we lost one of the speakers, we're just sort of opening this up to, as I said in the beginning, to any other question. Actually, really, whatever's on your mind is fine, but any myths that you guys might have, we have a couple that we came up with as we were prepping for Mitch's absence. Actually, Karen, why don't you hand? Oh, you have one, okay. I think you just have to turn them on. Okay, so no other questions? All right, so I think something that at least I hear all the time when I'm on service, and someone actually said something to me during the meeting that, oh, are you a cord blood transplanter? And none of us are just strictly cord blood transplanters. We're bone marrow transplanters or hematopoietic stem cell transplanters. So we don't do just one thing. But what I hear all the time when I'm on service is, oh, those cord blood transplant recipients, they have a really high rate of graft failure. So I'm posing to you guys, anyone who wants to take that on, do you guys believe that cord blood transplant is associated with high risk of graft failure? Filippo, go.
Is on? Is on? Yes. No, absolutely not. If you know what you're doing, the risk of graft failure is pretty minimal. If you follow the guidelines that we published, I can tell you that because you know better than me the experience in Seattle. We have a less than 5% rate of graft failure, and actually 5% is even overestimating. I think the last 150 cord blood transplants that we've done only one patient with graft failure. So if you know what you're really doing, it's really not a problem.
So guidelines. Anyone else want to comment on that?
I also wanted to add to that.
Yeah.
I think that there are maybe some center differences and in the practices, and probably that accommodate that, says that some people say that, but so far I haven't seen that huge differences in in that rates as well. So perhaps that is probably old myth as well. Probably not. Probably something that's true.
And we're going to have the answer, sorry, because we'd say guidelines, but Leland, who had to leave, so he's looking into this right now with the CIB and TR. And as you know, and as he showed to you the other day, we were so surprised to see that the majority of cord blood transplant done in the United States are done not following the guidelines. So it might be that the rate of graft failure that is perceived as very high is because of people choose the wrong units.
Yeah, go ahead, Joanne.
No, I would just add to that, if you have a patient who's at higher risk for graft failure for medical reasons, you can now pick Amisurge, which will give them 100 times the dose and much shorter engraftment, and can overcome medical resistance or disease-related resistance to engraftment.
Yeah, and I think you made a really good point about that being an old myth, and I think, literally, I was just on service in the beginning of August, and I still hear, it's amazing how hard it is to get these old myths to go away. So anything bad that happens to a cord blood transplant, it's because they got a cord blood transplant. Anything bad that happens to a conventional donor, it's because they just got a transplant, right? So it's fascinating. Okay, any other comments on that one? No, okay. How about this one? With the advent of post-transplant PSI and the implementation of post-transplant PSI for both haplo and mismatch unrelated, we saw a beautiful talk around, was it Martin who showed all that beautiful data? Martin, sorry if I got that wrong. Cord blood is no longer needed to ensure that there is a donor for everyone.
Okay, I'll take that one. There is a donor for everyone, but the question is, what is the best donor? And that is continually evolving. In the first talk, we heard that it's not just about picking a haplo donor, but there's cell dose issues, there's donor-specific antibody, there's HLA-B leader, and it's just continuing to evolve. So having as many options for people of all different race and ethnicities and backgrounds is really important, because we really don't know what the best donor option is for individual patients. One other comment on CTN 1101 is it didn't study ablative transplants, didn't study myeloproliferative neoplasms, didn't study people over the age of 70, which we know is a rapidly rising cohort. So there's a lot we don't know, and having as many options for patients and trying to figure this out as we evolve and we learn more about HLA typing and donor selection, I think is key.
I also wanted to add to that as well that, one of the slides that I was showing is that we were not able to have that European study, assigned in the same group. They had to cross over to the other group. About 15% of the haplo group had to do that because they did not have an haplo option. And to be honest, I think that depending on the patient's social situations, where things are, there would be incidences that only option they might have would be the cord blood options. And especially for those who are socially disadvantaged, I think that there had been a talk earlier, I do think that disparity would be bigger. So having that option is extremely important to consider all donor options.
Yeah, excellent point about SES, and I think, even if a haplo donor is available, doesn't mean they're available, to your point.
Yeah, and
right?
also, as Karen said already, as the aging of the patients going into the transplant is going higher, the haplo-identical donors may not become the best donor as well.
Right, and to that point, I was really impressed, or it stuck to me with Martin's talk again when looking at the availability of donors for pediatric patients, and it seems like it's getting harder, not easier, to identify fully matched unrelated donors for pediatric patients, and I assume that's just going to get worse and worse as those kids become adults. And maybe we won't be doing transplant by then, but we probably will be, so it's just going to get harder and harder to find donors for those kids, so please keep banking cord blood. Did you want to add to that?
No, I'm just clarifying, you're saying that I think because we're all mixing more and more.
Right.
And we don't have pure lines of ancestry anymore.
So our 20 million Caucasian donors aren't going to cut it anymore, right? I mean, I think that's an incredibly important point.
But I do think that we should identify where cord blood really can perform well. And yes, it is about donor. I agree with you, Karen. It depends on many factors and that needs to be taken in consideration. But I think there are some areas, and you know that I talk about this all the time, which is, for example, second transplant is becoming a huge part of our practice. And I do think that there are data out there showing that cord blood is not inferior to other stem cell sources. And from my point, and I think from an ethical standpoint, since second transplants are not associated with very good outcomes, the use of cord blood or overuse of a donor, I think as an ethical aspect, that should be taken in consideration.
So going to the bank where the donor's just sitting there ready for the second transplant.
And giving GCSF, because we forget, the donor gets GCSF, they get mobilized, and then at the end for what, for 20-30% survival? When you can obtain that with cord blood, they just go and do it.
It's not a no-risk situation, absolutely. Okay, any other thoughts from anyone? All right, cord blood is just a bag of stem cells. Oh, sorry, yes, thank you.
Sorry, I just realized I need to clarify Fran's statement on myth 1, number of transplants, because I'm representing WMDA cord blood working group, so I can answer on the number of transplants, on a decline phase. WMDA takes voluntary data from, I think, around 56 countries, over 106 institutions. That includes both registry and the cord blood banks. So these are not actively taking, it's more of a voluntary reports. That excludes clinical trials, immunotherapies, or anything outside the scope of hematopoietic stem cell transplants. So the numbers may vary, like China, CMDP reports as well, but that's only purely for an unrelated transplants. So the number you see in the annual report on WMDA is not actually outside the scope of what the WMDA wanted to share. So that is what I wanted to clarify. But you're right, there are other centers, because last year we started a cell therapy subsection in WMDA, which we will be taking into the other clinical trials and immunotherapies data, maybe in the upcoming years, so that you will have an updated report on an annual basis from WMDA as well.
Thank you. Okay, we'll do one or two more. So cord blood is just a bag of stem cells.
I'll take that one.
Joanne's favorite.
That's my saying, but I say it because lots of families contact me because a relative has some disease with an unmet medical need and they want stem cell therapy, and they see their cord blood unit or a relative's cord blood unit as a bag of stem cells that can correct whatever disease they're worried about. And we know cord blood is a heterogeneous product. There are probably 0.01% of the cells are true blood stem cells. There might be an occasional other stem cell of another developing organ that happens to still be mobilized at the time of birth, but it is not a bag of stem cells. Now, having said that, it's a bag of very interesting cells. Lots of them have therapeutic potential, as you've heard today. NK cells are not stem cells. Treg cells are not stem cells. CAR T cells are not stem cells, but they are in cord blood or can be manufactured from cord blood and have great therapeutic potential. So, but cord blood is not a bag of stem cells.
Great. Anyone else? Okay, this is another good one, and at least I hear this a lot too. We often talk about the time it takes to find a donor. And we often will hear that it takes a long time to access a cord blood donor for stem cell transplant.
So I'm going to start that one for two reasons. One, you literally can mobilize a cord blood donor through NMDP in about 5 days. And that includes the confirmatory typing. And now there are units that are already typed, so you don't even have to do confirmatory typing, and they will appear at the top of your search if you organize your search properly. And those literally can come in a day or two. And you know, to Filippo's point about second transplant, where you may need a unit overnight, cord blood can be obtained that way, and NMDP and banks facilitate rapid shipment. I think it also comes up in newborn screening and diseases that are identified that need transplantation in the first month or so of life. And I have heard through the grapevine of transplant centers saying, well, I can't get a cord blood unit, it takes 5 weeks. That's the longest time I heard. But you know, these are babies, Krabbe and sometimes SCID and a few other congenital marrow failure type diseases where they need a transplant in the first month of life. And they may have a genetic disease which is inherited, which means the chance they're going to have a matched sibling who's not a carrier is 1 in 16. And even taking the time to do that may not be appropriate. Cord blood gives them a great dose. It gives them a bone marrow dose because they're 2 to 4 kilos, and they get a huge dose from cord blood. They engraft in 7 to 10 days, and you can get the unit right away. You can do testing on the unit for carrier status of whatever the disease is, and that ought to be the treatment of choice, in my opinion, when you need to transplant a baby who's picked up through newborn screening, either with leukodystrophy or SCID or bone marrow failure, and needs an urgent transplant.
Yeah, and I just said, there's nothing quicker than cord blood.
Right.
I mean, if you're thinking about a haplo donor, that's like a person who might be working, has childcare, has to travel to the center, get all their testing done. I think the NMDP has done a great job in improving time to transplant, but again, you know, that's a live person that has to come and get retested, and the transplant is done around the donor's schedule, so there's nothing faster than cord blood.
Yeah, and we had a patient who lost their graft. I mean, literally had already started conditioning, and I can't remember what happened with the donor situation. It might have been even a family member, and we lost that. And I think we actually got a cord from your bank in 2 days.
Twice, but yeah, I agree with all that's been said. But I do think there is a part of the same problem, Colin, though, because I think transplant institutions, they really don't want to get off their track. And they didn't even try. As Haplo is taking over because it's very easy, and as a matter of fact, every transplant physician loves to do things that are easy and do not be very complicated. I think it's the same. I think it's the same reason here. But attached to this point, another thing that is perceived always very bad about cord blood, we have Jeff here in the audience, is the fact that even at Fred Hutch in Seattle, despite we have great outcomes, despite we do 35, 40 cord blood transplants a year, I cannot start conditioning regimen for a patient until the cord blood unit is in-house. And that's only for cord blood, which is an unrelated donor, right? Because, you know, during COVID, I raised the same problem. I said, look, but what is the difference between a person in Germany and the cord blood units in North Carolina? And they say, oh no, but you know, the cassette can come and it can be broken. Yes, but I think the flight can also go down and that's also not going to arrive. It tells you how much there is a perception of that things need to go wrong with cord blood. And I think it's very difficult to go over that bump.
Well, along those lines, at our center, I would like to make a plug for everyone out there, I guess maybe NMDP and other transplant physicians, at least at our center. You know, someone doesn't come to your transplant center until they have a donor identified, right? So all that stuff is done before. And so they show up at your center with their donor identified. And we have had a number of patients who are told, you know, oh, we can't find you a conventional donor, but good news, we found you a cord blood unit, right? And so it's already kind of setting this like underlying, you know, message, and they're like, great, we're going to get a cord, and then we start talking about all the benefits of having a cord blood transplant. They come to the center, they start their workup, but we don't stop looking for that unrelated donor. And then what happens? They're here, they think, oh, this is great, I'm getting a cord, and all of a sudden they're like, oh, guess what, we're changing your donor to an unrelated donor, because we happen to find one. So I would like to encourage anyone who's doing that to stop doing it, given all the data that's been presented here, and the fact that that's just a very confusing message to the patient who is about to go through a life-saving procedure. I'm probably preaching to the choir here, but just remember that if you go back. So, okay, I think if I may, I'm going to just close out this session, but I would like to say a couple of things ahead of time, and then I'm going to ask Joanne if she wants to say anything too in closing. I want to thank you all for staying to the bitter end. It is fantastic to see everyone and network, and we're so appreciative that you are here. You are the reason why the association exists. I would please, please beg and encourage you to go out and ask your friends to become members of the CBA. Without your membership, this meeting is not possible. So membership, sponsorship, all of that. So please, if you've had fun, again, please tag us, please spread the word. We would like to have more clinicians come to this meeting, so bring your friends, speak it up. And any ideas you have for next year's meeting, same time, same place, okay, not exactly the same time, but same month, same place, please let us know. We are going to begin planning for the meeting next year now. So you can write it on a piece of paper and hand it to me before you get on a plane. You can email afterwards, but please let us know what you would like to see. And one final thing, and then I'm going to let Joanne really close it out. I would just like to introduce Matt Farrow. For any of you who haven't, you want to stand up, Matt? For those of you who have not met Matt, he is a champion of cord blood transplant. He is the first recipient of a cord blood transplant. He loves to stay involved. He loves to hear what's happening. So he will talk to any one of you who want to give him an update on what you're doing and where you're going. And thank you for being such a champion. So thank you to you all. Joanne, you want to close it out?
Yeah, so thank you, Matt. It's 35 years, right? It's really amazing. Yeah, so I want to thank you all for coming. I think it's been a great meeting. I think the talks have all been wonderful. I want to thank AMC, our meeting organizers, and our management group for the Cord Blood Association. I want to thank all the speakers, all the people who made posters, our session chairs, our sponsors, our exhibitors, our planning committees, and everyone who attended the meeting and made it what it is, and all your contributions and all the interaction we had really made it special for me, and I hope for everybody else. So as Colleen said, next year, same time, almost same time, same place. Miami? Yeah, it's in Miami next year. I really am grateful we got in between hurricanes, and hopefully we'll do that again. I look forward to hearing from you and hearing what we can do better, what you liked about the meeting, what you didn't, and thank you all for drinking the Kool-Aid for a few days and enjoying cord blood and hearing all the things it's so capable of. And see you again next year. Safe travels.